our next session will be AI in clinical care, balancing innovation, safety, and trust. And that will be Renee Emmer from VCU Health. Come on up.
So good morning, everyone. I'm Renee Emmer, and I serve as the Vice President for Clinical and Revenue Cycle Systems at VCU Health. And I'm honored to be on the board of Virginia HIMSS, and my role today is to moderate. It's not about me, it's about these four guys on the stage here. And I want to find Lee. There she is in the back. I just want to thank you for putting so many ideas and thoughts in our heads this morning and for the first 45 minutes. So many things that we can build off of. The one theme that kept running through for me personally was the human-centered component of it all. Everything that Lee talked about came back to the humans at the center. And I'm going to say it, about 40 years ago, I became a nurse, almost 40. And the reason I did that is because I really liked people and the humans at the center. And maybe about 25 years ago, I moved from the bedside into the technology piece. And I think the reason I did that is because I knew there was a way to improve the technology that was coming and help just make it all better for the people providing care from an AI perspective. I think in all the roles that are represented here, you've all had components of implementing an EHR, providing patient care, the network guys, I know you're in there, out there somewhere, the stuff behind the scenes. Everyone here plays a different role, whether you're a physician, a nurse, a therapist, you train on the EHR, you might be a nursing student. I know we have some of those. And you can hear a lot of lessons learned about how to implement an EHR. But I don't think any of you have experience and wisdom and can say this is definitely what all this AI stuff is going to do to us as healthcare, as clinicians, as technologists. So we're going to pontificate a little bit today. With the one constant at the center is the humans. So thanks for joining this dynamic conversation. I'm out here because this has to be a conversation. We have four excellent CMIOs here, physicians who will have conversation about AI and what it's going to do to us in healthcare. I'll be asking a few questions, but I know all of you have questions as well. So jot your questions down and we'll save the last 5 or 10 minutes till the end. So as advocates for patients, as advocates for your peers, for the clinical care team, and also as advocates for innovation and AI. I'm going to introduce you briefly, and then we're going to jump into some questions. Dr. Hyder, I'm going to go from left to right or right to left. As a nurse, I get it mixed up as well. It's always someone else's right and someone else's left. So from the patient right, but that's my left. Okay, so Dr. Hyder is the Associate CMIO for Carilion Clinic. He's a board certified in internal medicine and clinical informatics. And besides messing with AI, he likes to cook for his family meals. Dr. Jeff Kim, the CMIO for VCU Health. He's a practicing family medicine physician and board certified in informatics. And when he's not dreaming about AI, he's watching sci-fi movies. Dr. Andrew Markowski is a CMIO at UVA Health. He's an emergency medicine physician. And when he's not thinking about AI, he's spending his Friday nights in the ED. And Dr. Amit Patel, CMIO, Augusta Health. He's an internal medicine physician, hospitalist, and I think all he does is play with AI. No, I'm just kidding. You like using AI to solve those really complex problems like scheduling residents. So, Dr. Hyder, what does it really mean to you to keep humans in the loop of all of this AI implementation?
Yeah, it really means we've talked about it these past few days in terms of AI being a co-pilot, but I think keeping humans in the loop really means patient-centered care. If we're talking about our entire health system, we have to enable our care teams to be more human as we grapple the headwinds and the massive deluge of data that we're getting. So it's really about, again, I'm going to use the phrase that we've talked about in the past few days, that AI being a co-pilot, not an autopilot, and really allowing us to have empathy, make the right decisions in conjunction with our patients.
Dr. Patel, what does it mean to keep a human at the center of our AI implementation?
Hello.
And is your microphone on?
I don't know. Can you guys hear me? So, the way I see human in the loop is you as a physician or as a clinician, you're at the pilot seat for a lot of AI technology. So if it's ambient listening, you're using AI as a co-pilot, but you're more or less reviewing everything that it's recommending. If it's not ambient listening, if it's like something like open evidence that gives you, that the residents use as a way to help with their clinical decision, they're using that as an assistant, not as a solution to, completely take over the decision making. So I think human in the loop, in my opinion, at least the way I see it, is essentially you're in the loop in making decision as opposed to having AI take over.
Dr. Markowski, I'm going to ask a different question and then you can weave that in. This is where I throw you for a loop.
Ready for that one.
Is there a chance we're going to become over-reliant on AI in all the healthcare we're providing?
Yeah, I think that this ties in nicely. So I'm going to use my original answer to help answer this question, which is, to me, I think they've said it well. The human in the loop means that the AI is not just completely automating some sort of evaluation and response. I think as our initial forays go, that's a good idea because, it's still a pretty high risk area as you diet patient care. I would also argue the contrarian opinion, which is that you lose some efficiency by doing that. I think the challenge for us is going to be deciding where we really do need to have a human in the loop and where we feel comfortable maybe taking the human out so we can realize the full benefits and efficiency of a lot of these automations. I think it's already pretty clear if you look at the way that our OPAs and our medication alerts work, that there's probably huge swaths of our clinical population that are just blowing right past them anyway. So the idea that we have a human in the loop for those, let alone with AI, might be wishful thinking at the end of the day. And so I think while it might be a good idea, to help lower and mitigate the risk, I think we have to acknowledge the fact that a lot of that human in the loop is going to quickly become just a fallacy, just like I think a lot of it is for other decision support.
Guess who's next? Dr. Kim, with the use of AI for critical decision making, clinical decision making, have you seen any occurrence of a hallucination? Or I guess first explain what a hallucination might be and how a human in the loop might either help or hinder that.
Yeah, so I mean, everybody's very familiar maybe with the example of this lawyer who used AI to prepare his legal brief, and it cited case law that didn't exist, right? The AI literally made up case law. And so that's an example of hallucination. And the reality is that AI does in fact hallucinate. And so when we talk about human in the loop, we're testing, or we are piloting an AI note writing, not just in ambient listening, but actually helping you write your notes and then giving you recommendations for your plan for your patient. Right now, it's clear in the note what is sort of just information gathering, and then there's a portion that's bracketed that sort of shows you what might be recommended based on guidelines. I can tell you that portion is not well trusted by our clinicians, right? Because they don't agree necessarily with everything that's presented there. Whether it's true hallucination or not, one, thankfully, a lot of these solutions do warn you that some complex reasoning is occurring and that there's potential for mistakes. But I can tell you that that portion of suggestion is probably the least trusted, with good measure. And so I do think there's definitely the potential for hallucination. And that's why you have to have a human in the loop for right now, right? It's kind of like, I don't know, maybe I'm being a little controversial here, but physician builders, if you have physician builders in your organization, right, initially there is not a lot of trust. Maybe they're going to break things. You have to build a relationship with them, and then you give them more freedom to do things that maybe you wouldn't have initially, right? The same is true for AI, right? We have to see what it's doing, look very critically, right? Make sure it's not making those mistakes before we really sort of give it more free rein.
I was just going to say, does anybody want to comment?
I'll
there?
jump in on that. I have an anecdote that's not mine. It's Inova is here. Andrew Miner and I, we're buddies. We live near each other. He's not here, he and I shared. We sat right next to each other on the way out to UGM last year, and so he told this great story that I thought was really compelling, which was open evidence. Right? I think maybe people are familiar with open evidence. It's basically ChatGPT in the background, but it's got the context of the world's leading medical journals as the basis for its information, right? So really important context engineering. He asked it a very simple question, which was, what are the doses of medications for intubating a pediatric patient? And he gave like kind of stuff. And it gave the correct meds. It gave succinylcholine and etomidate, but it gave a defasciculating dose of succinylcholine. I'm looking at my PDCM guy over there, right? So the totally wrong dose of the medication. It was an interesting hallucination. It pulled the right information, but for completely wrong context. And it also begs the question, does AI need to solve everything? Because if you were to use this to solve your question about medication dosing, you've essentially just bypassed all of your other decision support that you probably already have built into your order sets and preference lists. And so I think we have to be careful about turning AI into a hammer for everything, because it's not always the best solution. That to me was a very striking and great example. So
I'm going to just give a little side note that Andrew and Andrew are doppelgangers. They have the same voice. They have the same initials. They're both ED docs. So just decide. I think my favorite term for the over reliance on AI is techno-chauvinism. There's a reliance that you have to do that. And I think we're going to talk about education later, but really how these models are trained is critical. I mean, I think Andrew's example probably related to how the model was trained. And how do we account for that? How do we monitor that? And so folks aren't necessarily going to think about that when they use these tools. And so part of it is education, part of it is on us to make sure that that's safe.
I think let's move into the training piece, because not only training the AI, but training the people in the audience here who have to support this. And how do you first teach clinicians how to use AI responsibly? I'll stop with that question. What does that look like? Dr. Patel.
So I think that there are two pieces. One is obviously how do you educate the patient, and the second piece is how do you educate the clinicians. So I think it starts with educating the clinicians on what models they're using. I'd give an example of, I'm a hospitalist, and in medical school, you're taught statistics, and the reason you're taught statistics is because just so that you can actually review medical, randomized controlled trials and see what the benefit of certain medications or certain diagnostic test was. If you're not taught statistic in medicine, you're not going to be able to learn, or at least extrapolate, a lot of these randomized controlled trials, which you will base your evidence-based medicine on. So, in terms of teaching physician, I think it comes down to starting, fundamentally, in medical school. Hey, this is what an AI model is. This is how it's trained. These are the biases that it can have. These are the ethical issues with it. Right now we kind of use the tool as clinicians and not know specifically what we were using. We don't know if the model was trained. So I'll give an example of randomized controlled trial. We as physicians look at the patient characteristics, like what's their age, what medical problems they have, what's their race, because it matters. So if a medication was trialed on one specific population, you cannot use that you can't say that the medication will help in another population. So, things like that starts fundamentally by teaching in medical school. This is what you should think about, look at. So once physicians are able to or have the foundational knowledge on that, then you can sort of teach the patients, right? So, if as a hospitalist, when I'm admitting someone with CHF exacerbation or something like that, I tell them basically this is what you have in very simple terms. You should, if as a physician you know the fundamental, you can do that. If I as a physician don't even know the AI that I'm using, how am I going to tell the patients, hey, this is how the AI was trained, this is how the data is being used, that this is the bias that it has. These are the risks. These are the benefits. These are alternative, options. So I think it starts with physician and then it moves into patient education.
If you take Lee's aunt or uncle, who may not be technically savvy, but as a physician, you have a responsibility, I guess, to let them know if you're using any AI, maybe that you're using a listening tool. I'm just going to put my phone here and it's going to record everything. And how do you, with all the different types of patients that you see, how do you make it understandable? How do you help patients understand what you're using, why you're using AI, what it means to them, and do they care? That was a lot rolled into one question. Would anybody like to take a stab at answering that? Helping me or helping the audience understand, like, what do patients even need to know about it?
I think Andrew and I had a good conversation about this earlier. And I'm going to try not to steal some of your thunder, Andrew, because I feel like you
go for it.
We use AI already. Thanks, Trip. In our care. So what is, how do we get permission for that? I think that you don't need to complicate it by telling the patient what you're using. I'm using a RAG model. I'm using an LM. I know how to code. You need to be very clear about who's accountable and what the roles are. So we're using AI, but I'm making the decisions with you together. Because I think if you go down the path of specific details on what you're using, it's going to get very complicated across an integrated network of care. You're going to have to ask permission every time. I think it's really about roles and accountability.
Yeah, I don't think we should be asking patients if we should use AI or not, because there's no way that we could possibly honor their wish, and we're just going to tie ourselves in knots and get ourselves in trouble. How do they decline? Right? It's going to be everywhere. It's going to be not just in the EHR. It's going to be in the cameras. It's going to be in the security system as you walk into the hospital for weapons detection. It's literally everywhere. And these are the same people that are probably opening up Netflix and letting the Netflix suggestion box like determine what they're going to watch. I mean, mine's very confused. It's like a combination of Walking Dead and Sophia the First, because I've got 4 daughters and I'm trying to break the algorithm. So I mean, my thoughts are, there was a time in medicine where we asked people, we got their consent to test them for things like HIV or hepatitis, and eventually, as the stigma and all the anxiety stopped doing that. And I think we need to head there faster with AI. I think by asking the question, you make a bigger deal out of it than you should, and you put yourself in a position where now you need to argue with the patient. And I would suggest there's nowhere that they could possibly go anyway that could honor that request. And so we should take the notice of AI use and bury it. Everything else in those papers you get when you show up in the hospital, it's like in 4-point font. So we can fulfill our obligation to notify them, but we don't really need to open up that can of worms, is my opinion.
I will say, I mean, I agree with what Andrew's saying, but I will say, we're at an organization where we do require a written consent for using ambient note scribing. And I'll tell you why. It's not because of the AI portion. It's actually because of data, right? So I think the important thing that patients need to understand is what's happening to their data, right? Because that data is pricey, right? Companies will do a lot to get their hands on that data for a variety of reasons, right? Research companies will partner with you and they'll give you free services if you'll give them the data, right? And so I think that's probably the important thing that patients need to understand is what's happening to their data. I think the most important thing with AI and technology is the why. Right? When I put my phone down and ask a patient, even if they sign the consent, yes, and I explain, hey, I'm going to use this software to help me to write my note, right? It's going to help me to focus on you. 99% of the time, the patient's like, oh, of course. And even if they said no, once I explain what they said no to, they're like, oh, of course you can use it. Right. So I think the why behind why we're putting in predictive models, or the why behind why we're using radiology AI, right? I think if patients understand that, they're going to be a lot more amenable than if they think that we're trying to steal their data and do something nefarious with it.
So I was gonna say, the informed consent piece has 2 components to it. It all depends on if the AI is for support or is it a manager. Is it the decision support system or is it a decision managing system, right? So ambient listening is a support system, and the framework of implicit versus explicit consent revolves around that idea. If it's a support system, then I think it's completely fine to just say, hey, this is an AI tool I'm using to allow me to spend more face-to-face time, and then transparency is key there. But if it's an explicit consent needed because it's a managing system, so like a AI chatbot that essentially recommends, hey, these are my symptoms, this is what medication you should take, that should have an explicit consent, similar to procedures, I would suppose, that may have risk benefit and all of that profile to it. So it all depends on the the model as to whether it's assisting you peripherally or it's actually taken over. And data use is also, you need to have that data use agreement and make sure is who's if for ambient listening, I'm sure that data is not as significant as a predictive model that will actually use a lot of data. So is that data your healthcare systems data, or is this data the solutions data? And then you need to be transparent with your patients. So, I mean, the last thing I'll say is, I looked at a couple of surveys out there, and patients actually have low trust in us being responsible with AI, at least healthcare systems to be responsible for AI. There's a Theranos effect. I mean, there's a lot of events that's happened in the past that has caused that trust. So it's very important that we have that implicit and explicit consent in place, and we're transparent with our patients.
Just had a maybe cynical side note. I think for one, I think the data probably the crux of it. I really like that comment about it's really about the data and sort of how we use it. But who's going to get sued first? People for using AI or people not for using AI? I mean, I think that's a question you got to ask yourself. I kind of think it's for not using AI. We'll see, but and related to asking for permission and things like that.
Yeah, and I want to clarify, I'm not opposed to educating patients, but I don't think it should be an explicit every time you show up, we ask you if we can use AI, or drill down to should we use this AI versus this AI. I think it's more a matter of just acknowledging that it's like the energy. It might be a noble desire to have all of your care provided and powered by green energy, but there's no way we can do it. So maybe we could talk about what it means to be a LEED certified hospital, but we can't ask them if they're okay with us not being LEED certified.
We can't hear you.
So I was just saying that, the patient's ability to opt out, you could just have an implied consent. If they have any concern over it, they would say, no, I don't feel comfortable using that tool.
Yeah, I mean, we're at such an interesting time in healthcare right now because there's just so much information that we have to pick through, right? There's so many radiology studies, there's so many lab results, there's genetic data, right? And to expect people to do a thorough chart review for every patient that they see is getting more and more difficult and very easy to miss things. So I think to your point, right, there's definitely a risk of not using AI. Because that's what keeps some clinicians from completing their notes, right? Is because they're taking so much time to try to find the right information. And I'm one of those people, right? I like to click through the media tab and look at all the old records and try to make sure I'm not missing anything. And that is not really tenable when you're seeing a ton of patients. And so to the extent that AI can help us to do that, I think it's going to provide actually safer care.
Are we deploying AI in health systems or anywhere that perhaps some physicians, docs, nurses aren't comfortable with? Have you come across your peers that don't like it, don't want to touch it, don't want to use it?
Yeah, I mean, I think I've definitely heard from some of our docs locally at UVA that they have concerns about the black box nature of some of these Gen AIs. Are they equitable in terms of their outputs? I think those are real legitimate questions that I don't have a great answer to. So far, I have not heard of anybody refusing to incorporate AI into their practice. It's like a conscious decision. Sure, some people have chosen not to use DAX, but I don't think we've reached the level of just a full-on revulsion with AI. I think there have been some interesting cases. I think it was California where the Nurses Association, Kaiser maybe, I may have the details wrong here, but there was a pretty big revolt against the use of AI in their health system. And I think that speaks to the fact that not only are we needing to educate the patients, we also need to be educating our staff, because there is a legitimate fear. I mean, you hear it all the time about staff reduction efforts. And I think they have real reason to be concerned that this cost me my job if we deploy these services. Am I somehow at greater risk as the human in the loop if I disagree with the AI? Does that basically set me up for a massive lawsuit or loss of license? Those are sorts of things that I think are real anxieties that we do need to address as we deploy a lot of these different tools.
I mean, just this past week, somehow I've become in charge of making sure clinicians finish their notes on time. And so I had a meeting with a clinician, and I try to offer every tool we had, every support tool. I'll come shadow you. Are you interested in using our ambient note service? And it was a hard no. I was like, but you're 200 notes behind. Like, can I help you? And it was really, I'm not interested at all. So I do just like our patients. There's that 1% to 2% or small percentage that say no, don't use this ambient note service. I think there are clinicians. We're all normal people too, with our own issues with AI, and so we do run into it. But I'd say it's not very pervasive.
I think those are the same people that had problems with human scribes. As an ED doc, I've been using human scribes since 2013, and like there's a subset of docs that are just very peculiar about their node output, and they can't handle humans or robots.
Dr. Hyder, I wanted to ask you, are you seeing a difference with Virginia being rural and urban? Are you seeing a difference in patients that maybe are from a different setting, rural versus urban, in their expectations of using technology? Do you feel anything when they come into your office? And
Yeah, I think there is a difference. I think the similarities are probably more. Well, I'll talk about the differences first. I think in the higher rurality you have in an area, the access and the necessity of using these tools is more imperative to the care. So it's really, rural, I think, is more about access. I think in an urban, suburban area, that sort of patient experience, satisfaction is more felt. Access is needed in those areas too, but I think there's a difference in sort of expectations, and what questions a patient might ask. It's their own LLM of choice. But I think equity, fairness, how patients approach the tool are very similar. So you can have care deserts in suburban and urban areas as well, but I think that rural mindset of being close, tight knit to their community, but still getting the care they deserve, is felt more, particularly when you're caring for them.
So, I'm at Augusta Health. We're in I would say a rural community hospital. And, I second the access issue as a big thing. You have more scarcity of providers on the rural side. Then you have more or less a long way before you can get an appointment. So access is a big thing. One way to look at that is one strategy would be maybe you do telemedicine or telehealth. But then you go into another issue where there's a higher chances of not having infrastructure on the rural side, right? We have patients that are coming from West Virginia. They travel three hours to get to us to seek health. So even if you want to promote and strategize a way to get telemedicine in, they don't have broadband coverage in the mountains. They don't have the infrastructure. I mean, it'd be, I still practice as a hospitalist, and it's not uncommon for me to see a patient and I ask them to call their mother their daughters and sons, and they have a flip phone. How do you do telemedicine when you have a flip phone? How do you do a lot of these ways to connect with your providers? You can make a case of having low bandwidth telehealth where you communicate with the patients with text messages. But again, you need to have a cell phone and services for that. So, that's a big issue on the rural side, not having the infrastructure or broadband coverage, and you have added complexity of socioeconomic that also you have to keep in mind of. So, and I think one benefit would be something like remote monitoring, where you might not need high speed internet to check their blood pressure or things like that. So those are the things on the urban side. I grew up in the New York City area, so I want if I was there, not in the rural hospital or rural area, I'd want things, everything high tech. I want everything convenient with me. I want an omni-channel sort of experience. I want everything in just on my phone in one app. It's more about, on the urban side, it's more about making your systems that are currently existing more efficient to provide that kind of experience. So that would be my take for the difference between urban and rural.
So it's not every day that we have the time to pick the brains of 4 CMIOs, and I've hogged too many of the questions. So I wanted to look around the audience and see if you have some questions on this side, because on this side you can't. I'm staying on this side first because you can't see the panelists. So you just might want to ask a question of like what they look like.
We might not be able to see you guys because of the bright lights blasting on my eye.
Hey, thanks. Really quick question. I'm Mark McDonald. I'm a neurologist and founder of a digital health company. But where does software as a medical device come into play? And is there a responsibility for the health system to make sure that some of these vendors are getting it right and not skirting the line?
Yes. Yeah. I mean, that's the very short answer, right? Like, so it goes back to what Jeff was saying earlier about data. Where is the data going? And I think that from a health system perspective is a very big concern. What is happening to our patients' data when it leaves, for lots of reasons, privacy reasons, right? Like a data leakage event where the patient's information is now out in the wild. That can have reputational harm for the patient. It can have financial harm. There's also the matter of our data has value, right? And we shouldn't be just giving it away to people willy-nilly. We should continue to have control over that data so we don't devalue the same data that we have. And so there should be organizational structures in place that help to evaluate those different risks as you interact with the different vendors.
Yeah, I'll just say you want to talk about, your groups coming to you with weird requests, right? The AI requests are the weirdest ones that we get, right? We're we met this company. They promised us if we give them our data, like we'll come up with this brand new algorithm and we'll test it on our patients. And there's no FDA approval. This company hasn't done, they're looking for a partner, try to start something from nothing. And then when you actually look into these companies, they're actually not even, they're kind of fake, right? And so I do think, especially when you're evaluating diagnostic or serious software that's going to affect patient care, there has to be an additional 5 levels of scrutiny. And so definitely one of the questions we just talked about in our AI group was this issue of FDA approval, right? And are they have they gone through that rigorous testing or not before we do use any of those?
I don't think there's any way to keep up with analyzing each algorithm. The FDA cannot do that. We can't do that. So there's going to have to be evaluation on sort of rigor and process on how you do that. So you might be, I feel like, I don't know it so well, but I think the FDA is working on a sort of easy ramp for companies that practice those right behaviors. I think bias, knowing how the algorithms drift is very important. And it's more about how you analyze all of them as opposed to per algorithm at a time or whatever, or device one software at a time. And I think it's going to change. I think we don't even know how some of these algorithms work, right? When you have a reasoning model and OpenAI comes out and says, oh, it may come up with an answer before it goes through its reasoning steps. Like, I don't even know what that means. You know, like, how do we evaluate that? How do you know what's safe? So I think we got to give grace a little bit to the folks trying to get it done, but it's almost what are good behaviors as opposed to what are good algorithms.
And I think we have a question over here.
So I kind of alluded to this yesterday regarding cybersecurity, but AI is beginning. And it's a pop word right now. We're still learning from it, learning what it can do and where it'll go. So tied to that progress is fear and a lot of misconceptions to all of us, people using it and people learning what it is, and we don't even know. So in your respective settings and roles, how do you adapt these changes? And on our end, how do we learn to approach the adoption and utilization of the new tools where we don't know where they're going?
I think first off, we have to become more expert ourselves, right? Like that's one of the challenges I gave to all of my CMIOs this past year was you need to learn a lot about how to use these Gen AI models because that's everything. And so the easiest way to learn how Epic's Gen AI models work under the hood is for you to start using it in your own work every single day. Like if you're not doing that already, then you need to start doing that, right? So we play around with it, try to find different use cases. We share those insights with each other. Like, so one of the fun things I did recently was I made a chat GPT project and I put the color palette for UVA in there. And I said, every time I want to make a graphic for a PowerPoint slide, use this color palette, right? Like little things like that. I know it's silly and stupid, but like you keep doing things like that over and over again, and you start to understand how these models behave, like how important prompt engineering is, how important context engineering is, because that's all happening under the hood in these other models. You don't see it, but that's what Epic is doing with all of these models. So the better you understand that kind of stuff, the better you'll be at, I think, explaining it to your colleagues. So when you start to talk about, well, how is this art in basket being drafted? Oh, it's using the prompts, it's using the context of the chart, all of these different things. It makes you a lot more intelligent about that. So I think that's the first place to start, is to look within, make yourself better, your inner child better, and then look without. So
yeah, I'll say one of the things we're really struggling with is how do you not just educate your healthcare people, but how do you educate your whole organization on AI? I mean, there are companies that focus just on that. And so I think as IT experts, like we have to know these things, right? So that when these requests come in or when we're thinking about implementation, we're not just implementing what the business asks us to implement, but we're asking those hard questions as well and understand how, AI can go really well or really badly. I'm a Star Trek Next Generation fan. And so, you have the android Data, right? Who is amazing, right? More human than like any of the human characters or non-human characters, right? And then you have his like evil brother Lore, right? Who's AI too, right? And so AI can either be really, really awesome or it can be really, really disastrous. And so I think to the extent that we have to come up with a strategy to train our own people, and using it is definitely one way to see. But as IT experts, we have to understand AI, and then I think our organizations have to come up with a better strategy than just, the best that we can do right now is make sure that people understand our AI policy, right? But that's not training. That's not deep understanding of how these may or may not make their lives better. And this is the thing that keeps me up at night, especially at a teaching hospital, is for many of us that know how to work without AI. AI is our aid, right? It helps us. It makes us more efficient, right? But we understand the underlying that we can work without it, right? What happens when you have a generation of students and residents who don't know how to operate without it, right? They didn't really learn the fundamentals because they thought they could just ask AI, right? And so we have a downtime, and I already have clinicians who start hammer texting me and messaging me when our ambient solution goes down for a little bit, right? And these are experienced clinicians who know how to write notes, right? What are we going to do when they're wholly dependent on these AI aids, right? But we have a downtime, right? We already have residents who don't know how to write paper prescriptions, right? Nor can we really write paper prescriptions anymore, but that's beside the point, right? But that's what keeps me up at night is how are we going to teach them to use these tools properly? Because Andy or any of us up here, we can maybe see a recommendation and be like, that doesn't make any sense, right? That dose of etomidate is way off, and I'm not. But what about the learners that don't know? Right? They never took the time to really understand fundamentals. So that's what keeps me up at night. How do we use these tools effectively? Because they're going to have to use them whether they like it or not. But how do we make sure they understand the fundamentals?
Thank you. Thank you to the audience for your engagement. And I wanted to make sure we end with a quick word or a phrase or one sentence, because I know I'm over time almost, I think. Yes, I know. It says 0. What is it that you hope the members of the audience carry forward, Dr. Patel?
Well, I had a code.
Dr. Patel.
I wanted to give you an example of something, but we're out of time.
One word.
Well, this is an AI generated phrase. It's quite quite simple. I'll say the future of AI in clinical care isn't about replacing human touch, but about amplifying it, ensuring that every new technology we embrace helps us preserve the art of medicine.
Dr. Markowski, what's your word?
Wow, I didn't come prepared with the ChatGPT. I don't. I think my biggest takeaway is that the world is changing very quickly, and we all need to. I think we need to lean in the bias towards action. We cannot just sit around talking. A lot of our governance structures are just too archaic to keep up, and we need to become a lot more nimble in order to move forward. And I think, again, one of the best places you can start if you're not doing it already is to try using these tools yourself, so you can start to understand them a lot better and bring that to your colleagues.
Thank you. And I'm going to keep going to whichever direction that is, Dr. Kim.
Maybe 2 words. I'll just say for all of us here, optimism, because AI can do so much more than we ever thought it could in a very short period of time. And then hope, right? We're constantly under pressure as IT professionals to deliver more with less. But I think, our mindset should really be, we can do it, right? We'll figure it out. What we've always done in our entire careers is make something out of nothing. So optimism and hope.
I'd like to revise my answer. Adapt and overcome.
No. Dr. Hyder.
AI strategy. Now, that's a joke because I really wanted to piss Trip off because he's going to talk about that later. But so getting to your question, it's I'm gonna say it with a question. What does human-centered care look like? I think we need to ask that question with whatever decision you make. How can AI add the value to that question? So whenever you make a decision, whenever you're thinking about something, ask yourself that question, and you'll make the right move.
Thank you. Thank you, panelists, for your time, and thank you, audience,